Good morning, everybody. So I'm going to be giving you a PowerPoint presentation over Chapter 9 from the pharmacology text. It's the respiratory disorders and pharmacology. Just so you guys understand, I know these are boring, they're long, there's a million other things you'd rather do, but the point is that part of your taking this course is because you have a teacher who's an expert in this arena, and hopefully I'm able to help give you some direction in what material is important to understand or to know, or to help you to understand some things that maybe aren't very clear. But primarily it's as far as being technicians, what's important for you to know and learn. The other thing is, when you look at these chapters, these are massive. I mean, they're 50 pages, 70 pages, and we're not just talking about reading like a novel. It's pages that are packed with one drug name after another drug name after a different class of drugs. And then within each different class of drugs, there's side effects. And within each different group, there's different indications specific. There's some that are combinations, some that are unique. Sometimes you never use a drug, sometimes you always use a drug. And it's just the reason why pharmacy school, it's the reason why you have to go to school 6 years to become a pharmacist. It's because we do have to spend all this much time as technicians. We're covering all this same amount of material, only you're not really going to have to remember as much of the details, but you do have to remember important things. And in particular, it's going to be the drugs, exactly their mechanism of action, and when they're used. So I'm going to focus on that, but I'm going to go through the whole chapter. Keep in mind, just so that you can appreciate this, guys, the book, it comes with a pre-made PowerPoint presentation that's about 3 times longer than this. So I went through and I've created this in particular, and it's a lot of work. It might not look like it, but it's an awful lot of work. And I'm doing it in an effort to try to make this as convenient, or at least as focused, and minimize the amount of time that you have to devote towards this, so you can maximize your time working on memorizing your drugs, the things that are a priority. So anyway, Chapter 9, respiratory disorders, we've got asthma, chronic obstructive pulmonary disease. And COPD, that encompasses COPD and emphysema. We'll talk about those. Other lung diseases, like guess what? We've got the COVID-19, cough, cold, allergy, smoking cessation, and then complementary and alternative therapies. Once again, you're going to find the complementary and alternative therapies. People automatically assume that these medicines, just because you can get them without a prescription, just because they're out front by the vitamins, that they're harmless. Just because they come from nature, they're harmless. Well, if you look at, we have many, many drugs that are simply derivatives from some kind of extract, like linoxin, one of the most poisonous toxic drugs we have. It's derived from the foxglove plant. It's an extract. And so it's a naturally growing plant. And then you think, well, if it just grows in the wild, then it can't be too harmful. What about cocaine? What about opium, cannabis? So keep in mind, things that grow naturally, they have properties, and some of them have very powerful medicinal properties. It's just in the Western medicine, we're more based on scientific evidence. We want to see clinical proof of something, whereas in Eastern cultures, there's a lot more of the use of the complementary alternative therapies. The reason it's become a real priority in pharmacy, though, is there's a lot of drug interactions. Just to give you one illustration, ginkgo biloba, it's an alternative therapy that people use, and it's proving to be as beneficial as the best medicines we have on the market for Alzheimer's. The only problem is that somebody's taking ginkgo biloba and Coumadin. What's Coumadin? Warfarin. You got it. Warfarin was what? A rat poison. Now it's a blood thinner in humans. If you have too much in your system, you can have hemorrhaging, internal bleeding, and die. If you don't have enough, if it's not at the right dose, then you can have a stroke or an embolism, and either have a stroke or another heart attack. So anyhow, when you combine it with the ginkgo biloba, it decreases the effectiveness of the Coumadin. And so that's something that we need to be aware of. If somebody's using Coumadin, we need to know all of the medications they're using, even if they think it's something that's just harmless. Our objective is to just to be able to differentiate between the primary pulmonary diseases. So whenever you look at a lung or respiratory infection, what are the differences? What's the physiology or pathophysiology? What's the treatment for asthma? What about emphysema and COPD? Tuberculosis? What's the mechanism of action of antitussives, antihistamines, expectorants, decongestants, and then smoking cessation products? Something that you've heard me mention many times, one of the things that I love the most about pharmacy is we're constantly receiving customers or patients come in and they're looking for any kind of relief, something they can use that'll give them relief without them having to go see a doctor. And we have a whole arsenal of medications that they'll work. Once we know the symptoms, once we know if it's safe for them to take, we can make recommendations, and then we can make a significant difference. And so that's one reason it's just so important to understand the different OTC medications when they can be used. And so anyhow, that's just something that's, especially for pharmacists, it's one of the most significant contributions we can make as a healthcare professional. Asthma is a chronic inflammatory disorder of the airways. It causes coughing, wheezing, breathlessness, or chest tightness. So you can see this is an example of normal bronchiole in the alveoli. There's a mucus plug. That plug, whenever you have a plug, that's an obstruction, just like you're choking, but this is through just small bronchioles. And so you end up with bronchial constriction. So that bronchiole is constricted. You have a mucus plug, cuts off the circulation of air. It's reversible small airway obstruction. So what does reversible mean? It means that when somebody does have an asthmatic attack, that in time, it will reverse, it'll return to normal. It's a progressive airway inflammation. So progressive means that you have inflammation, and if it goes untreated, that inflammation is going to get worse. As it gets worse, it progresses, it just becomes even worse. So by the progressive inflammation, that just means your airway becomes even more sensitive to stimuli. Symptoms are wheezing, dyspnea, and cough. And dyspnea just means it's labored breathing. So the asthmatic response, it's an acute breathing difficulty. It's triggered by smoke, dust, exercise, pet dander, cold weather, even gastroesophageal reflux disease, and colds and flu. With exercise, some of you may have had asthma. A lot of times it's real common for children to have asthma and then they just grow out of it as they get older. But there's an exercise-induced asthma. And in that case, it's very common when you're working in community pharmacy, when you're dispensing an inhaler, you usually dispense like 2 albuterol inhalers, one for the parents to keep at home, and one for the child to take to school, and they keep it with them so that they can use before they go to PE, just to help prevent an asthmatic attack that's triggered by exercise. So long-term effects, tissue inflammation, airway constriction, so you're not getting the same amount of oxygen permeation, ultimately permanent lung damage. So this just shows the asthmatic response. There's a trigger, and remember the trigger can be smoke, it can be exercise, it can even just be the weather. That trigger stimulates the release of histamine. That's why whenever we talk about antihistamines, we have histamine 1 antagonists. That's the ones that you think of for runny nose, sneezing, watery, itchy eyes. Histamine 2 is the one that are for the gastric parietal cells. So when you release the histamine and other mediators, it causes bronchospasm and increases mucus production. So anyway, if you ever had the flu or you've ever been sick and you just keep continuously just making mucus and mucus and mucus, and you can be miserable because no matter how sleepy, exhausted you are, you can't fall asleep when you're just choking to death on mucus. How do we manage asthma? Well, the first thing we got to do is we have to assess the degree, the severity of asthma. So we have something here, this is called a peak flow meter. And of course, it actually has a disposable device so that not everybody's just blowing on the same opening. But you blow, and when you blow into this, you blow as hard as you can. And what it does, this little red arrow will go and it'll stop. And then based on, we have like the red, that means it's problematic. Yellow means safe. Green means you're in excellent position, excellent shape. And what they'll do is just based upon your age and based upon your history, they're gonna, these slide up and back. These slide up and back. So they might move the green up to the 250 and the red down to the 100, and then have somebody blow into it to assess. But they identify it as intermittent, mild, moderate, or severe. And intermittent just means it happens really spontaneously and very rarely, periodically, unpredictably. The severity, there's pulmonary function tests. You also look at the symptoms, and then you look at the frequency of relief medications. So what does that mean, the frequency of relief medications? Well, you're going to find the staple, the number one medication used when somebody's having an asthmatic attack is a beta-2 agonist. It's albuterol. Albuterol comes as a syrup, it comes as a tablet, it comes as a nebulizer solution, and it comes as an inhaler. Whenever somebody's having an asthmatic attack, especially the inhaler or the nebulizer are going to be the quickest acting because they immediately deliver these beta agonists to stimulate beta-2 receptors in the lungs. When they stimulate those receptors, it relaxes the bronchioles, and immediately you're halting or stopping those bronchospasms, and then you're going to have improved oxygen permeation. Now, by frequency, ideally, when you dispense an albuterol inhaler, it's not intended to be used around the clock. They're really used on an as needed for breakthrough pain or to prevent or breakthrough asthma, or for example, it's exercise induced right before somebody exercises to prevent an asthmatic attack. If somebody's having to use the albuterol more frequently, so most common is to see it used 1 or 2 puffs every 6 hours. And so if you start seeing somebody using it more frequently than that, that's an indication that it's becoming more severe. It's taking more of the medicine more frequently just to try to get the same degree of relief. And so again, this is the peak flow meter, and this is used by patients to measure your respiratory status. Here's another one. This is the Civilmed. And so this one right here, it actually has the red, yellow, and green already defined. And then PEFR, your peak expiratory flow rate. So the flow meter, you're blowing as hard as you can, and it's able to detect with this pressure how many of a pressure that you're able to blow with your strongest breath that you can exhale. And then they call that your PEFR. So how do we treat asthma? We've got quick relief, we've got long-term relief. Quick relief medications. So these are used intermittently. Remember, we had that word just a minute ago. So intermittent, that would mean, like, let's say that you have asthma tomorrow morning at 8 in the morning, tomorrow night at 9 p.m. The next day you don't have it at all. The next day you have it at 1 p.m. And so it's just like not continuous, it's not predictable, it's almost random. It's rare, but it still happens. And so the goal there is as soon as you start experiencing an asthma attack to get immediate or rapid relief. Long-term treatment. Now there's a lot of children, and many times they find out that it has to do with their living environment. For example, let's say that somebody has a whole lot of animals living in their house, and the animals have the pet dander. And if a child happens to be allergic or sensitive, they're going to be continuously just surrounded by that pet dander. And so they're going to be continuously be experiencing asthmatic attack. In that case, they're going to require round-the-clock medication, round-the-clock treatment. So you're going to find we're going to discuss, we have the beta-2 agonists, we have short-acting, we have long-acting. The long-acting, they're the ones that are intended, you use them twice a day, and you use them every day. And by using them every day, and because they're long-acting, they help deal with people that are continuously exposed to or having the asthmatic attack. So the quick relief, those are to provide rapid relief. That's just immediate, sudden relief. The long term, the goal is to get it under control and prevent future asthmatic attacks. Also, just noted here, you use them regularly around the clock. So if it's twice a day, it's every 12 hours, every day. So what are the devices? We've got 3 primary devices. A metered dose inhaler. This is the most common. It's been around the longest. By metered dose, that just means that it's predictable. They've invented it's a little aerosolized chamber, and it has a set number of actuations. Most of them, it's 200 puffs. So whenever you get an inhaler, it'll have 200 puffs in that inhaler. A lot of people that go home, they'll use their inhaler. After a couple of days, they'll bring it back. It's already empty. No, they just used it incorrectly. These metered dose inhalers, they go through extensive testing. They're highly reliable. So whenever you see a metered dose inhaler, that'll tell you how many actuations. And an actuation is just whenever you press it down and it releases a burst of the medicine. So it's a metered dose inhaler, and most common is 200 MDI. Dry powdered inhaler. Now they were a step up. It's an improvement for a number of reasons. But what it is, it's inhalers, and they have little tiny capsules or caplets. And when it's time to use a dose, whenever you open the unit, it has a little spinning like a clock, the cog in a wheel, that moves the capsule into a place. And then whenever you snap the lid all the way open, it punctures the capsule and makes this powder. It releases the powder. Then with these dry powder inhalers, it's not a matter of, one thing that's always been an issue with the metered dose, you have to be able to exhale. So you take a deep breath, then you exhale, and then you press it, and you've got to be breathing in as the medicine is being released so that you get the most of the medicine. Well, that gets real complicated, especially with children. It's kind of hard to coordinate. With the dry powdered inhaler, one of the greatest advantages, well, it punctures the capsule, the medicine, the powder's there. It doesn't leave the chamber until you literally suck it out. You inhale it. And so it's one way, especially if you have somebody who's having a difficult time cooperating with the MDI, a metered dose inhaler. With the dry powder inhaler, it's really interesting because you're able to get the full dose. Once we return to campus, I have several examples of actual inhalers, and I'll show you. It's interesting. In 2009, you could buy an albuterol inhaler. You could get one of them for $4.99. But then, because of the ozone and just a number of factors, environmental, we had to do something about the fluorocarbons. So they had to change the propellant that was in the Ventolin or the Proventil inhalers. When they did that, all of a sudden, it's called Proventil HFA. So it's a hydrofluorinated propellant. It went from $4.99 to $300 for a simple inhaler, just overnight. And then as time's marched on, now it's one of those things I've told you about, Me Too. Me Too drugs, or whenever there's a drug on the market and all these other drug companies, they want to get a piece of the pie. So they'll work with the molecule and they'll come out with a drug that's virtually identical. Then they'll go fight to get their piece of the share. Well, with the albuterol, there's not really a patent on the drug albuterol. And so it was a matter of there's just hundreds of pharmaceutical companies that are all spending vast amounts of money on different delivery systems. Keep in mind, because of the number of people that smoke, the number of people that even work for companies where they're exposed to toxic chemicals, COPD and emphysema is significant in the United States. It represents a massive amount of potential money for drug companies. They also see somebody that has asthma, chronic asthma, or COPD or emphysema. That's like money in the bank. They're not just going to be buying one inhaler and never again. they're going to be put on an inhaler and they're going to use it for the rest of their life. And so these drug companies, they keep coming out with one after another. We have a couple of different training units in the pharmacy classrooms. So once we're back, regardless of when we get back, I do want to show you those. You'll be fascinated. I think the thing that's fascinated me the most is how inhalers can just look so small and cost $400 or $500 just for a single inhaler. Then a nebulizer. Nebulizers, they're just machines and they have tubing. And what they do is they will disperse medications. They'll put them into fine particulate matter in a mist of normal saline or water, and it's dispersed. So it's delivering the medicine through a fine mist, and it can be worn as a mask. So here's an example of a meter dose inhaler. Every time you push down, it actuates this, and there's a pre-measured blast. And like I said, there's typically 200. Something that's unfortunate about the meter dose inhalers. Now times have changed. Now I even have a couple of inhalers. Every single time I push it, the number on top changes. So if I had 99 inhalations left and I used 2, it's going to show I've got 97 left. But in the past, you actually had to pull the canister off and then drop it in the sink that was full of water. And then you had to look at the angle of how it floated, and that's how you could estimate how much was remaining in the canister. So they've come a long way. An aero chamber or a volumatic, you're going to see here, this is where you plug MDI or inhaler into this end, into this end, and then you breathe through this end. This was designed especially for children because it is hard to exhale and then be breathing in and coordinating it simultaneously with actuating the MDI, the meter dose inhaler. So in this case, what happens when you push the MDI, the vapor, all that medication, it's trapped in this chamber, and then the child, or even if it's an adult using it, is able to breathe and breathe and breathe until they get all of the medication. The volumatic spacer, the only difference is you're still pressing the meter, the medicine's coming in here, but you can squeeze it with your hand, and that also helps to force the medication along. Now this right here is called an aero chamber, or an aero chamber with a mask. So you can see right here, this mask, it goes over the nose and the mouth. It's got a spacer, and the MDI plugs in here. And then here's another spacer. The difference with the aero chamber is it's got ventilated openings, and so you're able to actually breathe and breathe. You get a much better dose. It's more expensive, but it's much better for children. So you see with using a spacer, you have your inhaler, it plugs into the opening. Some of them, they actually have a whistle, so you can tell whenever the medication's been released. And then there's a blow valve and a mouthpiece. This is the Respiratory. What's so interesting about this, it's a small unit, kind of looks like a rocket. When you twist it, there's actually 30 capsules inside, little capsules. And when you twist it, a capsule falls down. When you hear the click, there's a piece of metal that pokes through and breaks through the capsule, releasing that powder. And then the patient's able to breathe. They just suck or inhale, and they get that whole dose. So there's no propellant. There's no hydrocarbon, fluorocarbon. It's breath activated. And so it's easier. Elderly people, they're not as coordinated anymore. Young children, it's very, very challenging for children. And then if you can only imagine, if a child's having difficulty breathing or having an asthmatic attack, it's going to be even harder to try to get them to cooperate using an inhaler. So these work real well with the children. The drug's formulated in a filler and contained in a capsule. It's placed in the device. It's punctured and it releases the powder, and then it releases the drug due to inspiration. So you're breathing in. It does require a faster inspiratory flow rate, which means you have to suck, or you actually have to breathe deeply. and then the flow required just depends on the resistance within the device. The nebulizer, that's just a means of administering drugs through inhalation. There's an equalizer that breaks up the solution to be inhaled into fine droplets. They're suspended into a stream of gas or a mist, and then the patient actively inhales. And we've come along with nebulizers. So we have nebulizers that you can have a great big nebulizer at home that's nice and convenient, does all kinds of things, records all kinds of data. They have nebulizers. There's one called a frog that they use for children that you can wear with, it's like a backpack. But there's a nebulizer cup and a mouthpiece. And so there's going to be the compressor. This is the unit that's going to be dispersing the medication with either saline or just sterile water. Here's another thing. And one thing that you're going to learn very quickly if you work, especially in community pharmacy, people, when they get their medicines, usually a doctor's going to write for a month's worth of medicine at a time. And so it's very common. Parents, especially on Medicaid, they'll come and they'll get boxes and boxes and boxes of the nebulizer medicines. But you want to make sure as a technician, and or if you work with a pharmacist that's alert and paying attention, they need to replace the mouthpiece and the tubing and the mask each time they're refilling. Why? Because these are, every one of them are potential reservoirs to be growing infectious agents. So there'd be nothing worse than using the same tubing over and over and over, cultivating some horrible infection. Or let's say that you have 2 or 3 children that are all using a nebulizer, they're all just sharing this, you'd end up passing around infection after infection. So good pharmacies, they get into that, they'll have a habit. They'll actually have near the front desk of the register, they'll have the excess hoses, masks, and medicine cups to make sure when people are getting refills that they're getting new tubing. This is just an example. So $500 for one unit. Like I said, when I first became a pharmacist, I think the most expensive inhaler we had was $13 or $14. Now these inhalers, they're up to $500. This Respimat, the technology's phenomenal, but it's just not. It would be one thing if we were such a rich nation and if just people had unlimited money to pay for this. But keep in mind, somebody who's got COPD or emphysema, they're going to be using 4 to 6 different inhalers. They're going to use them every day, and they're going to use them for the rest of their lives. So we're talking about several $1,000s a month indefinitely. And when you realize the numbers of people that have COPD or emphysema, you're just going to understand why all these drug companies want a little piece of the pie. They don't care how much, as long as they just get a piece of it. Okay, now with the asthma drug therapy, the most immediate therapy to relieve asthma. Asthma, when we're talking about just an acute or intermittent attack, we're talking about the short-acting beta agonist. The short-acting, it's the albuterol. This is the most important one of all, albuterol. Albuterol is Ventilin's a trade name, Proventil. Notice they both have vent, and then Pro-Air, but it's albuterol. They stimulate the beta-2 receptors in the lungs. Remember, we have beta-1 receptors in our heart. You got one heart. Some people don't have any heart. Beta-2 receptors in the lungs. You got 2 lungs. Whenever you stimulate the beta-2 receptors, it relaxes bronchial smooth muscle. You'll see here just there's some cautions and recommendations. When you have children under 5, they recommend a spacer. If they're under 4, it's a face mask. So the main difference is a spacer, you're just breathing through your mouth. The face mask, you're breathing through your nose and your mouth. Some of the formulations contain benzyl alcohol. That's actually just the max there. And then seek medical attention if acute symptoms are not relieved. Also, use a spacer device with an MDI. And remember, the MDI is a metered dose inhaler. And that again, you can just imagine for a child, it's very hard to exhale and then time it so you're breathing at the very same moment that you push the button and actuate. So here's some examples of the short-acting beta agonist. Ventilin's the most common. The Ventolin Accuhaler, this is one, it's salbutamol, and it's one that when you pull it open, it's got a capsule, it pops, and then you breathe through and you're breathing that powder. This is another MDI. This is another one that's a terbutaline. and it's another capsule release. I don't even know how this, I always just remember beta 2 antagonists because a tutor who tooted the flute tried to tutor two tutors to toot, so the toot of the tutor is that harder to toot, or two tutors to toot. And I was just saying like beta 2, and it's like albuterol or something. I don't know why, but I always made me just remember beta 2. So I put it there. Beta 2 receptors relax the bronchioles. You've got the short acting for immediate relief. Long acting are used to continuously stimulate beta 2 receptors to maintain relaxation of the bronchioles. Next, we have the corticosteroids. Steroids are like miracle drugs. You can take steroids by an injection, you can take oral tablets, you can drink the liquids, or you can use inhalers, and we even have nasal sprays. Now, the thing is, the nasal sprays and the inhalers, you don't get as much of a systemic absorption, so more of their action works locally or topically. However, there's consequences with the corticosteroids, and the biggest one is its effect on the immune system. So the greatest advantage, steroids, they inhibit inflammation. Whenever you have inflamed cells, you're going to have very poor perfusion of oxygen. So one of the main things it does is it minimizes that inflammation, and it allows for there to be better perfusion of the blood that's rich in oxygen. And then they're delivered through an MDI, never a DPI. If you do use the DPI, you don't shake it. Well, why wouldn't you shake it? Well, because the DPI is dry powder. You don't need to. The only reason you would shake something is the MDI if it's got a propellant in it. And so the most common one you're going to see is Pulmicort, and the next one would be Flovent. But just remember, so these are the corticosteroids. Corticosteroids, they end in, think of what's the cream you get? Let's say you get some ant bites, or you have an allergic response to something, you will get hydrocortisone. Well, most of them, they end in azone. Mometasone, so we take azone, beclomethasone, just like hydrocortisone. And then we have budesonide. So I don't know why that one got a different name, but these are the steroids. Leukotriene inhibitors. And so just the main thing I want to point out here is like Monteluk, L-U-K, Montelukast. And then you've got Zeferlukast. They're leukotriene inhibitors, and they've got that leuk in that name, so you would be able to recognize it. They work by antagonizing leukotriene receptors, and they only work really there. They have to be taken prophylactically. They don't work. They're no good or of very little benefit if somebody's having an asthmatic attack. However, somebody who suffers from asthma, especially if it's severe, there's benefit in taking or using the leukotriene inhibitor on a daily basis every day. And it's particularly in young children, especially young children that have chronic asthma. The most common one is Singulair. You know, it comes in a 4, 5, and 10 milligram. Then this one's a 5 milligram. It's chewable tablets. So, and they don't taste bad at all. So this is one that the children use, are very agreeable. Plus, the children that have asthma is scary. It's almost like you're drowning, even though you're not in water. When you're gasping and you can't breathe, it's terrifying. And so children, they do quickly realize if there's something that's helping them, they're wanting to try. And so the Singulair, it's something that's nice because as opposed to being an inhaler, it's just a little tablet that they take every day. And it's very, very effective at helping to prevent the asthmatic attacks. Mast cell stabilizers, these are a great big deal for a long time, and that was just because there was a lack of anything else on the market. And the mast cell stabilizers, they have to be used continuously. They're no good after you have an allergic reaction or asthma. So you can see right here, it prevents, which means you have to use it prophylactically. It's expensive. It went over the counter, but it's still expensive. You have to use it every single day. And then it's marginal as far as just how effective or beneficial it is. So you're really not going to be dealing with the mast cell stabilizers. It's just prophylactic only. And like I said, it's very expensive. You have to use it every day. Monoclonal antibody. Anytime you see a drug that ends in MAB, that means it's a monoclonal antibody, which means it's extremely expensive. And I just happened to see Xolair, a prescription on television last night. And I went and looked it up, $8,200 for a month. So this is for people, and it showed this grandma and a grandpa who are getting to go to their great granddaughter's wedding, which is going to be held outdoors. And they were afraid they couldn't go because they both suffer such horrible allergies until the doctor put them on Xolair. If you just think about it, honestly, if you didn't have insurance and you had to pay for your medication to treat allergies or to help with asthma, would you really be that excited about something that's $9,000 or $8,000 a month, especially knowing that it's only about 30% effective? And actually, they said about 1 out of 8 people whose allergies, symptoms, or asthma is triggered due to eosinophilia, and of that, only 30% effective. So it's not anything to get real excited about. It's just an example of a drug company that's jumped in. They've got something they're adding to the equation. But we have a ton of drugs. They end in MAB. When you see a drug that ends in MAB, that means it's expensive. It means it's a monoclonal antibody. And so this one, omalizumab, is $2,706. Do this. Smoking, vaping. Who said smoking? I'm 48 and still feeling good. Hold on. That was just a joke. Everybody want to see what my mom looks like. No, I'm joking. Okay, xanthine derivatives. We've got theophylline. Now, what's important about theophylline? Theophylline has a narrow therapeutic index. What does that mean? That means if you don't give enough, you might as well not be giving any at all. It's not going to do any good. It means if you give just a little too much, you might as well. It's like you're trying to kill somebody, because theophylline's a xanthine derivative. Caffeine is a xanthine derivative. So guess what? The side effects of theophylline, they're very similar to the side effects you see with too much caffeine. And how do they work? Well, it works in multiple, there's 6 different areas, but one of them, the most profound way is the respiratory muscle strength, the integrity of the muscle function. What are the long-term persistent medications used in the treatment of asthma? The long-acting beta agonists, corticosteroids, leukotriene inhibitors, mast cell stabilizers. Now, what is chronic obstructive pulmonary disease? Here's an example. So you can see right here, this is a healthy bronchial. This is not a healthy bronchial. And look at that. Which one do you think has much better airflow, much better perfusion of oxygen? Hold on one second, please.